Right, it's 8 o'clock and welcome to today's episode of Marvelous Medicine. The topic is what's new in neonatology. The speaker is Dr.N.Ambalavanan. He's the professor, Department of Pediatrics and co-director, Division of Neonatology at the University of Alabama at Birmingham, and is the director of Neonatology Fellowship Program. He also works with the Department of Cell Developmental and Integrative Biology and Department of Molecular and Cellular Pathology. He has several other academic appointments and professional consultantships, which includes being the director of the TREND program. I'm sure he will talk about it a little today. Dr. Ambalavanan did his MBBS from JIPMER Pondicherry and his MD Pediatrics from PGI Chandigarh. He went over to the United States and did his pediatric residency and fellowship in neonatology at the University of Alabama in Birmingham. He has also undergone training in clinical research and healthcare leadership. He's a passionate teacher and has guided over 20 doctoral and postdoctoral candidates. He has delivered hundreds of invited lectures all over the globe and received innumerable awards, one of the recent ones being the Dean's Award for Excellence in Research in 2020. He's a member of several councils and committees, on the editorial board of many journals, and a reviewer for scores of journals. His research interests include basic science, clinical, and epidemiological research, and he has over 200 index publications. He continues to have close ties with India and developed the software and automated neonatal entries for PGI Chandigarh, and is on the International Editorial Advisory Board of the Medical Journal of Armed Forces of India. Welcome, Ambalavanan, and thank you for accepting to give this talk today.
Thank you, Vidya, and it's really good to see all of you. It's good to be back home virtually, and it's, I think, great to see people with who graduated from JIPMER, some of them with me, some of others either before or after, and some of my teachers as well. So I'm sure that not everyone here is a neonatologist. So I'm going to organize this presentation into three components: an introduction to neonatology, because many of the people who probably graduated from JIPMER many years ago, neonatology is very different 30 or 40 years ago worldwide compared to what it is now. Some of the recent advances, and if time permits, maybe some of the future advances, what's happening right now and how it might impact medical care in the future. And many of these are true for all of medicine. It's not just for neonatology. So I think it's important to realize that intensive care is intensive care, regardless of where it is in the world. And also technology, which is used in developed countries now, soon become worldwide within a few years. So, introduction to neonatology. So most of you know that the neonatal period is the first month, or actually the first 4 weeks of life. The perinatal period currently is defined as 22 completed weeks of gestation to 7 days after birth. So the two terms are not the same. So neonatal doesn't necessarily mean perinatal. Infancy generally is used for the first year of life, and we use the term preterm or premature infant for infants born before 37 completed weeks of gestation. And term obviously is after 37 completed weeks. So a low birth weight infant is birth weight less than 2,500 grams, and very low birth weight is less than 1,500 grams, and extremely low birth weight less than 1,000 grams. So the reason I became a neonatologist and do research in neonatology is because I think of the importance of newborn health. So globally, 5 million children died before reaching their 5th birthday in 2020. And infant mortality is the largest contributor to under 5 mortality. And of infant mortality, neonatal mortality is the largest contributor to infant mortality. So newborn infants contribute the most to infant mortality, and infant mortality contributes the most to under 5 mortality, and under 5 mortality contributes the most to pediatric mortality. This is a figure from the UNICEF. It's not in very bright colors, but anyway, you can see the global mortality rates and number of deaths by age in 2020. So the y-axis is the deaths per 1,000 live births, and this bar you see on the extreme left is neonatal. And the next bar is children aged 1 to 11 months. And after that, you have 1 year to 4 years, 5 to 9 years, and so forth. So you can see the biggest bar is the newborn infants, followed by children aged 1 to 11. And this panel on the right, you can see the number of deaths in millions and the percentage. So under 5 mortality is this big blue bar. And of the big blue bar, you can see that neonatal mortality is the largest proportion, followed by 1 to 11 months, followed by larger infants. So newborn mortality is the big contributor to pediatric death worldwide. And this is a geomap looking at the world and the incidence of under 5 mortality in different countries. As you might expect, Africa is the one where you have the highest under 5 mortality, and others, tropical countries and South America also have higher under 5 mortality compared to some of the other more developed nations. But it's important to know that tremendous improvements have happened over the past 30 years or so. So this one shows the improvements in under 5 mortality. The light blue bars are the figures from 1990. The slightly darker blues from 2000, and the dark bars are from 2020. So over the past 30 years, you can see the marked reduction in under 5 mortality. And each of these groups is a different, I would say, category of countries. For example, Sub-Saharan Africa on the extreme left, and Australia, New Zealand over here, Europe and North America over here. So whereas in Europe and North America, there's a significant drop from say 14 to 5. Even in Sub-Saharan Africa, the magnitude of drop is probably more marked, from more than 180 down to 74. So there has been tremendous progress worldwide in under 5 mortality. So I usually want to make the point that this is probably the best situation it has been for children worldwide since the beginning of humanity, because never before in humankind has childhood mortality been so low, and it is continuing to drop. And it's important to know that pediatric mortality decreases are what is actually contributing to expansion or extension of the lifespan. We often say that people used to live for 40 years or an average of 40, 50 years, 100 years ago. Now people live to 70 or 80 years. And the reason people are living longer is not because of improvements in, say, cancer care or improvements in cardiovascular care. It's because of reductions in pediatric mortality, specifically improvements in newborn and under 5 mortality. Because you save one infant's life, you're giving them 60 to 80 years of subsequent life. Whereas if you save somebody who's 65 years old from having a MI, then you might give them an additional 5 years of lifespan. So a single child saved is equal to probably a dozen adults. So now we move on to neonatal mortality, and this is per 1,000 live births, again from 2020. You can see again that Africa is the worst hit, and India is also having slightly higher neonatal mortality. But if you look at the figures below, there has been a huge improvement in both infant mortality and neonatal mortality in both India, US, and globally. So for example, neonatal mortality in India was about 57 30 years ago, and now it's down to 20. In the US, it was 6 30 years ago, and now it's down to 3. It's going to be hard to make much further improvements in the developed countries because there is only so low you can go. And this is just a figure showing for the US, the infant, neonatal, and post-neonatal mortality rates, showing the marked reductions since 1940. So why are we so interested in preterm babies as a neonatologist? That's because low birth weight infants are much more likely to die, and especially if they are very low birth weight or extremely low birth weight, they're much more likely to die in the first year. And there are some racial differences too, at least in the US. African American babies are twice as likely as white babies to be born low birth weight, and therefore they have a higher mortality rate too. So why are we so interested in preterm infants? Preterm babies are made the cover of Life magazine. And this gravestone you see is that of Patrick Bouvier Kennedy, one of the children of John F. Kennedy, who was the US president in the 1960s. So he had a 34-week infant who was about 2 kilograms at birth, who died basically of respiratory distress syndrome. Currently, those infants have a survival of close to 100%. But in the early 1960s, the technology and the medical care did not really exist to save such infants. Right now, we take care of infants who are really small, ranging down to about 22 weeks and 350 grams in size. And many of these infants graduate off ventilatory support, are able to breathe spontaneously, and go home. This is one of our world record holders, Curtis Means, the baby you see on the left. He was born at 21 weeks and 1 day gestation, and he was only 420 grams at birth. He ended up staying in our hospital for 275 days, and now he's almost 2 years of age. Here he is posing with his mother and the certificate from the Guinness Book of World Records. So survival by birth weight increases with advancing birth weight. You can see that once an infant is close to 750 grams, their survival is excellent. And the problem is more of a global issue because around the world, there are about 15 million preterm deliveries every year. And the overall incidence of prematurity is between 10 and 12%. And in developed countries, between 5 and 12%, depending on multiple factors. And preterm infants contribute disproportionately to mortality, morbidity, cost of medical care, long-term disability services. And IQ scores, for whatever they're worth, are inversely related to birth weight to a certain extent. So for example, here you can see how the brain develops over time. So at 34 weeks, the brain probably is only about half the weight of a term baby's brain. And the amount of sulci and gyri really start developing only after 27 weeks. And even at 34 weeks, it's only half as developed as a full-term infant's brain. And this is something that we know by looking at serial MRI or by ultrasound. You can actually estimate the maturity of a fetus or a newborn infant by looking at the amount of sulcation and gyration of their brain. So the problem is when you are born early, you might have interruption of this normal process and persistent abnormalities in development. So this is the global prevalence of neurodevelopmental impairment due to prematurity. So one of the reasons that this is actually more common in countries like China and India is not because they have more preterms. Well, it's because they have more preterms, but it's because they have a larger number of births to begin with. So if you have a higher population, you have a higher number of births, and of them, more are likely to be born preterm. So it's just a question of numbers. In the US, this is the data from the Neonatal Research Network. If you look at survival to discharge at different gestational ages, you can see 22 weeks, 23 weeks, and so forth. Survival to discharge is close to zero. It's actually only about 5 to 10% for 22 weeks. But then starting at 23 weeks and onwards, you have an increasing amount of survival. This survival to discharge without major morbidity at the same gestational ages. And you can see that We have made some progress over the past 20 to 30 years, but still there is a substantial rate of handicap in these infants, even though they survive to discharge. So that's about preterm infants. We also have a problem with birth defects. So currently in the United States, the commonest cause of neonatal mortality is not prematurity, but it is birth defects, because we have a substantial number of infants who are being born with birth defects who then die of the defects. Not all the defects can be treated surgically or medically. So globally, about 6% of births will have some birth defect, not all of them major, many of them are minor. But 94% of births and 95% of deaths occur in middle and low income countries because they have a lot of the population. And which defects are common? So the common birth defects of genetic or partially genetic origin are 25% of all defects. So not all birth defects are of genetic origin. Some of these to which genetic influences contribute are congenital heart disease, neural tube defects, hemoglobin disorders. I mean, we don't think of them as a birth defect, but it is something that's genetic and can affect mortality. Down syndrome, G6PD deficiency, and so forth. There are also post-conceptional birth defects such as fetal alcohol syndrome, iodine deficiency, congenital infections, which also affect. So now we shall move on to the recent advances. The top 12 recent advances are treatment of retinopathy of prematurity with vascular endothelial growth factor inhibitors, treatment for spinal muscular atrophy, antenatal surgery for myelomeningocele, rapid whole genome sequencing, using antenatal steroids at earlier gestational ages, recognition of developmental origins of adult disease, newborn screening, not just PKU, advances in neonatal surgery, recognition of hazards of late preterm birth, advances in neonatal resuscitation, probiotics, and therapeutic hypothermia. So the first one we'll be talking about is VEGF inhibitors such as bevacizumab. This is something similar to what they use for diabetic retinopathy, actually the same principle, because vascular endothelial growth factor is a mediator of retinopathy of prematurity. And this study, which was published in the New England Journal, showed that ROP recurrence was 4% in the bevacizumab group versus 22% in the laser therapy group. So a marked reduction. And it is mostly for zone 1 ROP, so that is around the fovea and macula. And this is just a picture showing how it actually works. So on the right panel here, you can see that this is after conventional laser therapy. You basically burn the peripheral part of the retina so that that retina basically dies and you don't have vascular ingrowth into the vitreous, which then causes retinal detachment. But then you give the VEGF inhibitor, and that suppresses the VEGF, allowing the blood vessels to develop normally. Moving on to spinal muscular atrophy, there are two major strategies. The one is a gene replacement therapy, where adenovirus carrying this SMN complementary DNA, which encodes for the missing protein, or nusinersen, which is also called Spinraza. That's an antisense oligo that modifies the SMN2 gene. So that makes the full-length SMN from the SMN2. So it's two different mechanisms of treating SMA, and both of them are somewhat effective. So this again was published in the New England Journal a few years ago, a single-dose gene replacement therapy. And again, the sample size was pretty small. 15 children with SMN1 received gene replacement therapy. And in contrast to historical cohorts, all the infants survived to at least 20 months and most reached motor milestones. The other study was also published in the New England Journal the same year with nusinersen. And this also showed that those who received this agent were more likely to achieve motor milestones and less likely to need assisted ventilation than those who underwent sham procedure. And these are the survival curves showing nusinersen probability of event-free survival and probability of survival is markedly improved. Next, we move on to antenatal surgery. So not everything is a medical advance. Some of them are surgical advances. And this, for example, is one of the fetal surgeries. It's been shown that if you do antenatal surgery and you fix the myelomeningocele before the infant is born, the outcomes are better. So this is the MOMS study, management of myelomeningocele study. And this looked at 158 patients whose children were evaluated at a year of age. And they basically showed that the primary outcome of death or need for shunt by 12 months was 40% shunt and 68% death or need for shunt in prenatal versus 98% in those managed postnatally. So from 68% to 98%, that's a pretty big difference. And if you look at the composite of mental development and motor function, again, that was better in the prenatal group. However, if you do surgery before birth, there's an increased risk of preterm delivery and uterine dehiscence. This was also published in the New England Journal about 10 years ago. And this is kind of invasive, obviously, because you have to make a uterine incision, fix the neural tube defect, close the uterus, and hope the infant doesn't deliver preterm. And surgical repair also holds up. So prenatal surgery reduced the need for shunting and improved motor outcomes, but was associated with maternal and fetal risks. Nowadays, there are newer methods such as endoscopic fetal surgery, so you don't have to make a big uterine incision, so that reduces the risk of uterine dehiscence and preterm labor. And this is just some images showing how it's done through the endoscope. So it's also been shown to improve motor outcomes. And it's actually been shown to reduce hindbrain herniation, the amount of CSF accumulation in the posterior fossa, and the periencephalic spaces. So I think there's an increasing trend towards doing this through endoscopy. The next major advance is rapid whole genome sequencing for critically ill infants. So we often have infants in the NICU or the PICU who have an acute illness, and we don't really know why they have this illness or what the cause of the illness is. It may be a very non-specific presentation. And there's been an increasing interest in doing a rapid whole genome sequencing for such children. So in this study, 57% of these children were diagnosed by STAT sequencing, there is rapid sequencing, versus only 9% by standard genetics. And if you look at the time to diagnosis, it was 5 days for the genome analysis and 23 days for the routine analysis. And does it really make a difference? So acute clinical usefulness was noted in 65% of those infants with a STAT sequencing diagnosis. And of them, 4 had, there's 20% had diagnosed with favorable effects on management, and some were started on palliative care. So you may either know how to treat them, or you might be able to direct them towards palliative care earlier. Now it's even shorter. So the previous paper was in 2015, and this paper published last year in the New England Journal described rapid genome sequencing in 13 hours, so less than a day. And this identified a newborn infant with thiamine metabolism dysfunction syndrome. So this is a time course. So this infant presented to the emergency department with irritability and insoluble crying for 2 hours. And this infant was admitted to the NICU. And once the sequencing was started later that evening, they were able to identify that this infant had a thiamine metabolic problem. They started biotin and thiamine. The irritability and seizures resolved, and the patient was discharged home later. So this is something that can be done very quickly. Now, can it be done at a population level? So this is Project Baby Bear, which is incorporating rapid whole genome sequencing in 5 California hospitals. And it's been shown that it improves clinical outcomes. So 40% received a diagnosis by rapid whole genome sequencing, and it also led to changes in medical care. And overall, it reduced the cost of care, because rather than keeping a child in the hospital for many days without a correct diagnosis, you might be able to achieve more rapid diagnosis. So you might think that the cost is prohibitive, but the cost of sequencing is dropping rapidly. The current bottleneck is not so much the sequencing cost, but the bioinformatic cost. Who's going to analyze the data, and how long is it going to take them? Next, the use of antenatal steroids. Previously, people used to give it only after 24 weeks, but now we know that it's useful even at 22 and 23 weeks gestation. So these are the outcomes in terms of mortality, with even a partial course of antenatal steroids showing a reduction in mortality at 22 and 23 weeks of gestation. This is going to be of interest to the people working in or taking care of adults and older children. So that's about the developmental origins of adult disease. So it's been known for a long time that low birth weight and intrauterine growth restriction leads to increased risk of coronary artery disease, stroke, and type 2 diabetes. And higher birth weight is also associated with adult obesity. So there's been increasing recognition of the role of epigenetic modifications. So it's not just the genome, but also the epigenome that's important. And some of these epigenetic changes may be transmitted for generations. So we don't really know which sequelae of preterm birth and NICU care are because of structural lesions, say a bleed in the brain, intraventricular hemorrhage, and which of them are epigenetic and can potentially be transmitted to subsequent generations. Newborn screening. So this is something that's, I would say, commonplace in many countries, but many developing countries are just starting to do them. And it used to be just for thyroid or PKU. But right now, we screen for many genetic disorders. So right now we do it for 29 genetic disorders and 15 secondary disorders. So more than 40 of them. And each year, in a population of about 5 million people with about 65,000 births, we identify about 200 infants with a problem. And this is just a list of all the problems. I'm not showing it so you can read each one of them, but just to show that there are multiple categories: amino acid overuse, endocrine disorders, fatty acid disorders, hemoglobin disorders, organic acidurias, various other disorders such as galactosemia, cystic fibrosis, hearing loss, SCID, and so forth. And these are some of the confirmed diagnoses in the recent years. The commonest ones are hearing loss, congenital hypothyroidism, and sickle cell disease. But we have diagnosed many other rare conditions as well. Advances in neonatal surgery. Again, there have been many advances in cardiac surgery in terms of gastroschisis. Most of them are closed by placing a silo rather than immediate closure. And for neurosurgical management of hydrocephalus, the ETV CPC, also known as endoscopic third ventriculostomy with choroid plexus cauterization, that has also become increasingly popular because that may sometimes avoid the need for a permanent shunt. There's also increasing recognition of the hazards of late preterm birth. I mean, we used to think that most of these infants would do fine. But even though they survive and most of them do well, there's higher rates of short-term and long-term morbidity. Short-term, obviously, they have higher rates of respiratory distress, hypoglycemia, hypothermia, jaundice, and so forth, readmissions. Long-term, we know that they are at higher risk of pulmonary disorders, wheezing, increasing nocturnal cough, minor deficits in cognitive function. And there's also an increased risk of neurologic, psychiatric, and developmental conditions as they get older. Relative risk of attention deficit disorders is 1.7, for cerebral palsy 2.7, schizophrenia 1.3, and so forth. Higher risk of psychiatric and anxiety disorders and so forth. So it's not that it's okay to be born late preterm. It's a higher risk condition. So as far as possible, the best place for the fetus is in utero. There have been many advances in neonatal resuscitation, such as the PDCAP, which is basically the color-changing device for confirming endotracheal tube placement, the laryngeal mask airway, which is really useful if you are unable to intubate in the delivery room, and of course the use of polyethylene bags and heated mattresses for preventing hypothermia in the delivery room and soon afterwards. Tracheal suctioning for meconium is not needed anymore, thanks to many studies worldwide, including studies done at JITMA. Right now, we don't routinely suction all the babies at birth. Oral suction, it's been shown by a study from the baby that wiping is just as effective. For preterm babies, one of the complications is sometimes developed as necrotizing enterocolitis, which is about 5% of all extremely preterm infants. And currently, we use probiotics to reduce NEC or death, but most of the drugs that are, or at least none of the probiotics that is available right now is marketed as a drug. They are marketed as food supplements, which means that there is not a tight control over their manufacturing or what exactly they contain. But still, if you look at overall meta-analysis and systematic reviews, the reduction of NEC with probiotics is about 50%, reduces mortality, and also potentially reduces late onset infections. So therapeutic hypothermia has been shown to reduce neurodevelopmental impairment or death in hypoxic encephalopathy. At least in developing countries, there has been a recent study called the HELIX study, which indicates that the population of HIE infants in developing countries may be slightly different, but still most of the studies done to date have shown that NDI or death is markedly reduced in therapeutic hypothermia. So there have been 11 large randomized trials with more than 1,500 infants, and it reduces death or neurodevelopmental impairment by about 25%. And this is done by cooling the infants to 33.5 degrees Celsius core temperature and keeping it at that for 72 hours and then gradually rewarming for the next 6 hours. Now, this is just a plot to show the reduction in death or handicap by therapeutic cooling. Okay, let me stop here and see if there are any comments in the chat and if our things.
You can go on, Ambalavan, and you can address the questions in the end. No problem.
Oh, okay, sure. Okay, great. Okay, so future advances. So let me go through this in the next 10-15 minutes. So future advances, well, maybe Zoom is actually an advance because we really have a way to transfer information worldwide in a much shorter way rather than actually traveling to those places. But in terms of actual practice, I think biomarkers for earlier diagnosis using multiple technologies, advances in point-of-care testing, such as point-of-care ultrasound, advances in drug therapy, such as personalized pharmacotherapy, advances in disease endotyping. Previously, we used to treat all diseases like they're the same, but now we know that there are multiple endotypes of disease, which I will talk about. Advances in prognostication, such as trajectories of outcome. Advances in treatment of respiratory failure, such as NAVA, server control of oxygen, pumpless ECMO, artificial placenta. Advances in the identification and treatment of sepsis and infections, specific antibodies, rapid molecular diagnosis, prevention and treatment of multiple preterm disorders using exosomes or stem cell therapy, and finally preventing preterm birth. So this is one of our work looking at biomarkers for earlier diagnosis. So I mentioned that preterm infants are often likely to get chronic lung disease called BPD or bronchopulmonary dysplasia. And we can actually predict it using multiple biomarkers even as early as day one. So this is looking at what is called as cellular bioenergetics or oxygen consumption rates of cells isolated from the umbilical cord on day one. So we are able to predict outcomes that happen many months later by just looking at cellular bioenergetics. And the panels here show that the AUC or the predictive accuracy is pretty good. Point of care testing. So neonatologists are people who are very impatient, people who want results right away. So we like to do tests at the point of care. So just like you check glucose at the point of care using a glucometer, now we have been working with various companies to develop point of care testing for multiple other tests. For example, this is for acute kidney injury biomarkers. So we often think of serum creatinine as a marker of renal failure, but serum creatinine takes a long time to change. You need 50% of your kidneys to be knocked out before your creatinine goes up. So now we look at other biomarkers, including markers like cystatin C, NGAL, IL-18, osteopontin, and so forth. So we are working on methods so that we can actually test this at the bedside. So this is a digital microfluidics cartridge. Let me see if I can pull up the video. Okay. So for example, here you can see a big drop. That's a drop of blood. All you need is one drop. And you can see that gets split into micro droplets, which are then driven by this digital system. So they go down here, and you can see that these micro drops go from one place on the chip to another, and then it reacts with various reagents. So you can do things like immunoassays, you can do PCR, you can do colorimetric assays. So you can do multiple assays on a chip using just a single drop of blood. So whatever test that you need to send a lot of blood to the lab, now you can do it on a single drop of blood close to the bedside. Other things, point of care testing is the point of care ultrasound. So I personally believe this is more useful than a stethoscope because you can actually get a good structural assessment with ultrasound. So for example, with a point of care ultrasound, you can look for cardiac function. You can see if the cause of ascites, is it a particulate material or is it just clear fluid? You can look for a head bleed, intracranial bleeds in a preterm baby. You can look for pleural effusions. You can see if there is a kidney stone. I mean, you can do a lot of things with a point of care ultrasound, and this is a pocket-sized device. So multiple such point of care ultrasounds are present: a GE, a Butterfly, IQ, Clarius, and so forth. Philips has one, the SonoQ has one, multiple probes, multiple accessories, multiple costs. So this is probably one of, I would say, the major advances in medical care. And this is true not just for the NICU. This is something that all physicians everywhere can carry in their coat pocket. Okay, moving on to personalized pharmacotherapy. So this is something that's becoming increasingly important. There are more than 50 medications for which you may need to make therapeutic management recommendations based on the pharmacogenomics, and which may affect the safety of response and where gene-drug interactions affect the pharmacokinetics. So there are several arrays, such as a pharmacoscan array, which will look for more than 4,000 variants and 1,200 genes. And this table, which is hard to read, just basically tells us many of the pediatric hospitals where they have pharmacogenomics implementation process. So before you prescribe a drug, you would check their pharmacogenomic status to see which drug is best and what dose is optimal. Disease endotyping, as I mentioned earlier, many neonatal disorders have distinct endotypes as well as phenotypes. So it's back in the 1940s, people used to treat cancer by giving them methotrexate. And that was the only drug they had. So that was the only thing they could do. In the 1930s, when penicillin was just being discovered or being developed, people only had the sulfas for antibiotics. Now you could actually identify the sensitivities of the bacterial infection and give the specific antibiotic. The same way for most neonatal disorders, we're able to identify the endotype of disease. For example, bronchopulmonary dysplasia, is it more of a parenchymal lung disease? Is it a vascular lung disease? Is it an airway disease? And treat them appropriately. It's not like just giving everybody steroids and like you would treat somebody with, say, an autoimmune disease. Right now, we have more targeted therapies and monoclonal antibodies for such conditions. So I would say we are now able to recognize endotypes of disease and treat the specifics. So ideally, we should treat endotypes based on the underlying pathophysiology. The probability of an outcome is not constant, but it changes over time. So we have actually developed multiple models by which you can determine the outcome at different time points. Just 1 second. So, for example, this is the outcome at of 2 different infants, 23-week 450-gram male and a 25-week 750-gram female. So, a different time point. So, you can actually see that the outcome changes over time based on the different things that happen to them. So, it's not like you assume that the prognosis you give somebody at the time of birth holds through accurately till they're discharged from the hospital. And this is true for all things in medicine. So the prognosis you give somebody when they first come into your clinic or hospital is different from the prognosis they have when they leave the hospital. Next is respiratory failure management. NAVA, or neurally adjusted ventilatory assist, is something we do quite frequently these days, especially for chronically ventilated infants. So we have a esophageal probe, which picks up the diaphragmatic signal or the electrical activity of the diaphragm. It's called EADI. And we're able to use that to trigger the ventilator. So the ventilator is able to synchronize with the baby's breathing. We also have servo control of oxygen, at least in Europe. So it's not new, but there are various regulatory hurdles. So basically, you can look at the pulse oximetry reading and use that to address the oxygen concentration. So if the pulse oximetry reading falls, then you give more oxygen. If the pulse oximetry reading is higher, then you decrease the oxygen. There are actually 2 ventilators where you have this closed loop system, and it's been shown to reduce the duration of mechanical ventilation. The next thing is pumpless extracorporeal lung assist, also called a lung assist device or an artificial placenta. So this is basically a device to oxygenate the blood and return it to the fetus. So we have done some work on that in piglets, so newborn piglets, where we have shown that it helps reduce mechanical ventilation, reduce lung injury, or for hypoxic pulmonary hypertension. But right now, people are taking it much longer. So this is a study where they had an artificial placenta system, and they supported an extremely preterm lamb for 4 weeks ex utero. So basically, this is the lamb early in gestation, and then 4 weeks later that they maintained ex utero. So even if a baby is born preterm, in the future, you could potentially put them on the system and keep them growing with this artificial placenta for a few weeks till they're more mature. Preventing and treating infections, there's a new drug called nirsevimab, where a single dose can prevent RSV for infections. Right now we use a drug called Synagis or palivizumab, which needs monthly injections. So this is a single dose injections which reduces hospitalization and lower respiratory tract infections. There are also newer methods for diagnosing infections, such as the Caries Test. So you take a single sample of blood and you send it to them, and they would do PCR for more than 1,000 plus pathogens, more than 900 bacteria, fungi, DNA viruses, other eukaryotes, including Plasmodium, Naegleria, Toxoplasma, and they give the results back very quickly. So it's a bit expensive, but you get results back quickly, especially if you're having an infant with pyrexia of unknown origin. There are also the BioFire panels, which do something similar, where they have, for example, they have a meningitis encephalitis panel. So it's one test, and you need just 1 hour with 0.2 ml of CSF, which looks for 14 pathogens, 6 bacteria, 7 viruses, and gives you a result pretty quickly. There's also a blood BioFire panel, which looks at 43 targets, and they have similar panels for other organ systems. Say for people who are orthopedics or people who are GI, you can have separate panels. This is something that's really hot in the literature right now, exosomes and stem cell therapy. But I would caution that this is still, I would say, highly experimental. And right now, still in phase 1, phase 2 trials. Most of the studies so far have been in animal models, but it's very highly promising. Preterm birth, again, if people prevent preterm birth, I will be out of a job, but I'll be glad for that. But this is something that's, again, under a lot of investigation. There are many genetic markers for prematurity, and there are multiple, I would say, pathophysiologies which contribute to prematurity. And probably in the next 15 to 20 years, we will have some way to reduce the number of preterm births due to specific causes. Okay, that's the end. Let me stop sharing and see about questions.
Thank you, Ambalavanan, for simplifying the talk so that even those who are not neonatologists could understand. So moderating today's session will be Dr. Arvind Chenoy. He's the Clinical Director, Neonatology and Pediatrics at Rainbow Children's Hospital, Bangalore. He did his MBBS from Government Medical College, Mysore, and MD Pediatrics and DM Neonatology from PJ Chandigarh. He runs a fellowship in neonatal intensive care. I mean, he did his fellowship in neonatal intensive care in Australia, and he's a fellow of the National Neonatology Forum, India. Thank you, Dr. Arvind, for joining us. I will quickly introduce Hari as well, and then you can take the discussion forward. Co-moderating will be Dr. Hari Bhaskar Srinivasan. He's a clinical professor at the Ross University of Medical School and chairman of pediatrics at Sinai Children's Hospital, Chicago. He did his MBBS and MD Pediatrics from DIPMA Pondicherry and residency in pediatrics and fellowship in neonatology at the University of Illinois at Chicago. He has several peer-reviewed publications, abstracts, and poster presentation, and is credited for having authored a book. Thank you, Hari, for joining. Over to you, Arvind and Hari.
Thank you, and good evening, and Ambal. That was a wonderful talk. Hari, would you like to say something?
Yeah, thank you. Yeah, Ambalavanan, that was an excellent overview of neonatology, first for the general practitioner, and then you highlighted the recent advances in neonatology. And that was a good summary of the growth we have seen in the field over the last decade. And also you emphasized and looked at what are the future prospects and directions for future research. And I just wanted to bring up a couple of small issues, whether you can talk about them. One was, I know in our neonatal practice, especially recently over the last few years, we have had an increased emphasis on delayed cord clamping. And that would be a good emphasis for the audience here, because most of the people here are areas where this would be of a lot more significant benefit than what it could offer to our babies.
Yeah, definitely. I think, yeah, delayed cord clamping does improve outcomes. And I think it should be done in pretty much all deliveries. I mean, not only does it improve I mean, I would say iron stores and all that, but especially in a preterm infant, it might stabilize the blood pressure, reduce the rates of IVH and other bad outcomes in the short term. So yeah, definitely, I think delayed cord clamping is useful, but I would caution against doing cord milking, because I think cord milking may potentially be associated with some side effects. So I think if you're going to do delayed cord clamping, I think probably waiting for 30 to 60 seconds, if in the absence of fetal distress, would be a good thing to do.
And especially in low and middle income countries, this would have a benefit with absolutely very minimal investment of any kind of capital expenditure, which would cause significant improvement in our care of the babies, definitely.
Hari, if I may add, Ambal, I think in that category would fall kangaroo mother care.
Yes.
It would be the least low tech with very high yields.
Oh, definitely. Yes. Yeah. I think kangaroo mother care is something I did not include, because I think kangaroo mother care, delayed cord clamping, breastfeeding. I mean, I thought all those were established for the past 20, 30 years. So those were, I would say, established advances, not recent. Yeah. But I agree. I think, kangaroo mother care is something that most people already do, both in LMICs as well as developed countries. It's something that I think is important. And there are some questions in the chat. I think one about erythropoietin for neuroprotection. I think it is still experimental. The large trial of that in preterm infants, the peanut trial, did not really show any benefit. The question is whether erythropoietin in combination with therapeutic hypothermia may improve outcomes. I don't know, and we have to wait for some of the HEAL studies that are to be completed. So potentially, I think there are multiple therapies for hypoxic encephalopathy in addition to erythropoietin, like xenon, topiramate, exosomes from stem cells. All those are probably going to be useful. Now, about testing for sepsis in developing countries, and I think that's a good question. I think blood culture is still the gold standard for diagnosing sepsis, but there are people who have used clinical definitions of sepsis and gone ahead and treated with antimicrobials with good results. Now, the problem is you want something that is that provides rapid results, and something that is accurate, but also something that is cheap, and that is difficult to do. You know, they say you can have good, fast, or cheap, and you can have only 2 out of the 3. You can't have all 3 at the same time. But I think that's where technology will come in. There are many of these point of care tests that eventually I think would be useful even in developing countries. Right now, I think it's still experimental. But until then, we still have the blood culture to go on, and empiric treatment. The problem with empiric treatment, obviously, is that there is increasing antimicrobial resistance, and especially because everybody gets treated with antibiotics, and most of the bugs we see in developing countries are resistant to most antibiotics. And about the lowest, go ahead, Dr. Srinivasan.
Can I ask one question? Of course, recently, Indian Journal of Pediatrics kicked a row about use of hypothermia, and there were criticism about that particular paper. Dr. Bhatt is there, he can ask, because he has also written a comment about that.
Yes, I've read the comments.
I am sure you are aware of that particular controversy.
Yes.
It was biased, that's what many people thought. So I would like you to tell what you
so definitely.
Mr. Bhatt, you can further this thing, a lot of papers had come subsequent to that controversial paper. So I think I want this thing input about it.
Yeah, good question. So this controversy, I think, is about the Helix study, which Sudhin Thail and others led a multi-center trial in India, Bangladesh, Sri Lanka, to reduce HIE-induced death or disability. And they didn't really see an improvement. But other studies from India, including some from JIPMER, have shown significant benefit. And I think the question is it because the populations are different? Is it because the patient selection is different? I think all those are true, but I think if you look at the vast majority of evidence, like I showed you the meta-analysis and systematic reviews, the evidence is that hypothermia does benefit, at least for infants who have an abrupt or intrapartum event. For infants who had an episode of asphyxia in utero or distant to delivery, those who have seizures soon after birth, then you're not going to improve very much, because ideally you want to start hypothermia soon after birth. So I think there are differences in populations and
because it is Sita Shankaran who started that from USA, and
yes,
then it percolated down.
Yes, yeah. So maybe Dr. Vishnu Bhatt might be able to add.
Good evening. So I joined a little late, so I didn't know what was actually discussed. Of course, a lot of controversy has developed because it was picking up very well in India, therapeutic hypothermia. In JIPMER, we are doing for more than 10 years, and DM, PhD, MD, so many theses also have been done. And my personal experience and others is that there is a dramatic improvement with the cooling. And this controversy has come up now. The basic problem is the selection of cases. Suppose already irreversible brain damage occurs, then it cannot be reversed by therapeutic hypothermia. So in Western countries, you have transport cooling, you are having good resuscitation facilities, which I think is lacking. That is why in institutions where they conduct delivery, they cool, the outcome is very good. Whereas outbound, it's plus minus, depends on how you take it. Even JIPMER, none of our studies, we included any of the outbound babies in our study. Although they were cooled, they were not included in our research studies. We have taken only inborn. As you know, most of them do not come in within 6 hours, so they disqualify based on the timing one. Secondly, we don't know what happens to them, because what resuscitation, they come with one slip or they may not come with any slip. So we don't know what really happened. And that was the major issue which we faced. And we have looked at the DNA damage. We have looked at the oxidative stress. So various parameters, including renal function, myocardial function, all these different things have been assessed. And our finding is that remarkably they improve. And I am quite convinced. So also all the consultants and residents who are working. Only thing is this study has caused a lot of confusion. So it was going a steep uprise of cooling, which now probably the upright has slightly flattened because people are confused. They don't know what they are. That is one thing. Secondly, what happens is it is labor intensive, especially when you don't have a servo controlled cooling. So what happens, a lot of manpower time is spent. So obviously, whether it's a doctor or a nurse, spending time is also equally important. Unless they are committed, they will not do. So if you say that it is not useful, people are happy. So we'll give phenobarbital or some anticonvulsant. We give them some fluid, they are happy. That is, I think, the way people are looking at it. But those who are committed, I think Aravind Shana is also, I'm seeing there. Yeah, I don't know whether he is putting in his place. But wherever I go on St. John's, and of course, every examination we used to drill them on therapeutic hypothermia. But that slightly flattened. But I am thinking that whatever research you do, we should have the outcome in mind, whether you are doing good to the people or bad to the people. So that is very important. Study helix, I have no problem. Only thing is the way they interpret the selection criteria, what they've done. there are major issues.
Speak.
They are not.
Put your
I think I should not take too much of time. I could see Hari Bhaskar also in between.
Yeah. Hi, Dr. Bhatt. Actually, your summary is pretty appropriate. So I think the conclusion of the paper was a little bit harsh, saying that cooling should be uniformly not performed in low-income countries. So that was a pretty harsh statement to make. I think what you say is a very important statement. As long as you have good criteria to select patients, you have all the data available, you have the results of the resuscitation, you have the results of the cord blood gases available, you have a good neurological examination done within the first 6 hours of life, and then you institute cooling with a neonatal intensive care, which is equipped to take care of these infants, you should have similar outcomes as you see in developed countries.
Yeah, I think that's a kind of art. Yeah, I think I agree. I think that was a very strong statement that they made. I think just stating that they shouldn't do cooling is a very, I would say, extreme statement.
One more point, we had a panel discussion after that helix, where Sudhin, Sita Shankar and all people were there. So I told him, your intention does not appear to be straightforward, because they are doing studies on brains uncooled. Now they are doing studies, 2 studies are going on, which ethically is wrong. But they are doing these studies in India, which they cannot do anywhere in the world. So I said, your intention is to get cases for your studies rather than helping the patients. Then, of course, Sudhin walked out after that. Anyhow, I don't repeat what I said. I told what I felt. I told them, your intention is not help people, but you want to improve your research, and at the expense of poor people who cannot raise their voice. I think the statement was very strong, but I don't repent for what I've said.
Dr. Arvind, would you like to respond to that? What is your practice?
Most of the centers in Bangalore are cooling, sir. We totally agree with what Professor Vishnu Bhatt said. And wherever there is good antenatal care and resuscitation has been appropriate, babies have been monitored, and when they fulfill the criteria and we have cord blood gases, we do cool. I think I agree with Professor Vishnu Bhatt and the Helix trial, because they conducted in centers which are dealing with predominantly outborn. I think they should have re-looked at that data, specifically sorting out those babies who had chronic versus acute on chronic versus acute asphyxia. And maybe that would have thrown light. But I totally agree with Professor Bhatt, and we do continue to cool. However, for the educated parents who are Google savvy, we do tell them about this study, which has been mentioned, and we say, in spite of that, we have strong reasons to believe that cooling will help your child before, and we take informed consent before starting the baby and cooling wherever needed.
And if you
Vidya, can I say something?
Yeah, sure.
So yeah, I mean, I was just going to point out that this is probably one of those examples where people are comparing apples to oranges without making sure, and I see this in a big portion of how RCTs, randomized control trials, are typically interpreted. You really have to look at the inclusion exclusion criteria to be very carefully to make sure if that is relevant to your patient population, or if the comparisons you're making to different studies are relevant. And if that is not done, obviously you're going to have these weird sort of situations that people find themselves in. And based on all of the discussions that I've heard, particularly what Dr. Vishnu Bhatt said, it is very clear that these are the you're comparing outcomes from 2 separate studies where they use a different criteria for inclusion in the study.
And 70% of their cases were from one center, and they themselves know what they are doing. So these are some of the issues. Another good example is antenatal steroids. See, they published the data in Lancet and other journals showing that antenatal steroid in developing countries and poor countries not used. Now again, they have reversed it, telling that it is beneficial. So I think people make publication without looking at the real outcome and what benefit or harm they will cause to the public.
So we have Dr. Leela with us. Dr. Leela, what's your practice? Leela Kamat?
Yeah, hi. No, we are also cooling. Just like Dr. Arvind said, we are taking consent from the parents, and definitely when it's inborn and it's been referred from a center who tells us what's exactly happened, we do follow the criteria. I agree with Dr. Vishnu Bhatt completely. Where it's an acute event and the resuscitation and the details are well known, we really should not be denying treatment that is recommended worldwide to patients that we know have been born in ideal situations.
Thank you, Dr. Leela. Dr. Gayatri, an obstetrician, is also logged in with us. Dr. Gayatri, how useful did you find this talk, and you have any comments?
Yeah, I think there was a question about what's the low-hanging fruit for developing countries. And I think the distinction between developing countries and the developed world, I think it's a somewhat arbitrary definition, because the way I see it, a baby is a baby everywhere. They have the similar problems. I think it's a social and environmental situation which is different. I mean, RDS in India is the same as RDS in the US, which is the same as RDS in Ukraine or England. I think what matters is how they get access to care and where they are born and how the supportive care is, because it's, I mean, a lot depends on maternal nutrition. It depends upon postnatally, who is available to support resuscitation at birth, what kind of infrastructure is available, and is there a respiratory therapist available? Are there, is there sufficient, I would say, expertise in long-term follow-up in screening for ROP, things like that. So I think it's more the infrastructure that's different, but the problems are similar.
We also have Dr. Shanti and Dr. Mahadevan with us. Dr. Shanti, your comments, please.
Glad to see them all. Yes, good to see my old teachers, Dr. Shanoy, Dr. Vishnu Bhatt, Dr. Srinivasan, Dr. Mahadevan, Dr. Shanti. It's good to see you all.
Hello, nice to see you. It was an excellent talk, Ambalavanan. I really enjoyed it. Your flow of language was beautiful, and you talked very well. No, this only one thing. This about this developing and developed. Even in our country, there are some excellent centers which give a level of care that is as good as in USA.
Yes,
maybe
probably better.
Only, probably they're accessible only to a few. So it's, as you say, it's only the infrastructure. Maybe the public sector, they are not able to bring it to that standard, but private sectors do well, some of them at least.
Yes.
Dr. Mahadevan?
So, sorry, Ambal, I was the one that asked the question about low-hanging fruit. It was not meant to say that diseases are different, but there are certain interventions that give you a greater ROI. And, you know, that was what I was going for.
Yeah, and I think the most cost-effective ROI would be in training people, because I think once you train people, it's not so much lack of resources, I think, but knowing what to do for certain situations. Yeah, I mean, we are go ahead.
I would like to point out there about the neonatal resuscitation. I didn't know that NRP as a structured program was introduced in 1987. It's not a very, it's only been in place for 30 years, but there's still a huge scope for it to be taught structurally to a very large amount of population in low-income countries, which would significantly improve your neonatal outcome, because still HIE is a major cause of neonatal mortality in these babies.
Yes,
Yeah, Dr. Mahadevan was there briefly. Dr. Mahadevan? I mean, he just turned his video on. Never mind. Go on, Ambal.
Yeah, no, I mean, we work with some global neonatal research networks. So we do work in Zambia, in South America, and other countries. And we have found that we have had effect at the country level. That is, we are able to reduce neonatal mortality at a countrywide level by training the traditional birth attendants in many of those countries in resuscitation. Basically, we give them a bag and mask, a self-inflating bag, and we teach them how to bag babies, basically those who don't breathe at birth. And just by doing that, we are able to reduce markedly not only the number of babies with HIE, but we are also able to reduce the number of stillbirths. Because previously what used to happen is many of those babies would be labeled as stillbirths, but now they're actually being recognized as live births, because once you bag them up, they start breathing.
I think Dr. Narayanan is doing similar work. I just read a post in our group.
Narayanan, who started the neonatology unit in pediatrics in Jipmer. She was working in Lady Hardinge, Kalari, and in a private hospital later. And she has been regularly going to Ghana and other places, you know, in African countries and trying to establish excellent resuscitative procedures system. And agreeing with Namachiva and Ambalavanan, so much of work is being done in these areas and the privileged countries, and things are improving.
So Arvind, so sorry, I was going to say that Arvind, the traditional dye kit that those, the community medicine used to hand out in PGI to all the dyes now probably needs to have a blade, a tie, and an ambu bag, huh?
I would agree with you. I think ambu bag and also probably a regional language course. What I have been asking NRP to do is a regional language course of NRP. I think in NNF Karnataka, I think we are working towards that, because as long as it is English based, it doesn't percolate to the dye level. So we probably need to do it in the local language. But excellent suggestion. And also we need to have a way of easily keeping this bag sterile, because that we need to figure out, because obviously ETO or Cydex sterilization is some of the problems we are battling with. But excellent suggestion. Thanks, Ravi.
So, I must actually thank Suma for suggesting that we get Ambalavanan for talking on Marvelous Medicine months ago, and I thank Ravi Shankar, A.K. Woody, for following it up, and Ambalavanan for making time in his such a tight schedule. It took me hours to just read his CV, so you can understand. He must be having 48 hours in a day. So, so Suma, your comments, please.
I mean, Ambala has always been phenomenal, right from the first year when I joined MBBS. He was a great senior in so many different dimensions, and he's just showed his progress once again. If I was to say, I'd already put a question in the chat which he has answered. Because as a pediatric rheumatologist, when I enter NICU, it's almost always because their child is suspect as a primary immune deficiency, and could I help with the diagnostic process, or go with that thing. So it was fascinating for me to see the rapid genetic sequencing that he described. Courtesy a couple of Wellcome Trust generous grants that researchers in Manipal have obtained, we now at least have access to free whole exome sequencing for patients where we are suspecting problems. But getting rapid answers is still not possible for us. And so that is a main Waterloo, because many of these children actually have illnesses that can be tackled. And that, it's one of the things where you can bring down both neonatal and infant mortality rate if we are able to address this scenario well. Actually.
Yeah, and I think partly we have to thank our colleagues in adult cancer biology for that, because they do all the sequencing studies for their cancer. So that's brought down the cost of our sequencing. The problem is finding somebody good at bioinformatics who can actually analyze all the data rather than actually doing the sequencing. Yeah, soon they say it will be cheap enough that anytime you want to do a sequencing, you can do it. It will be cheaper than actually getting many of the other tests.
I mean, the future will really be a pharmacogenetic horoscope and a whole genome sequence,
Yes.
exome sequencing for everyone. That's going to be the blueprint of your diagnostic and treatment paradigms.
Yeah.
That will be the future. I'll be dead by then, but anyway.
Have all the questions in the chat box been addressed, Hari and Arvind?
So there was one more question about specifically looking at fetal surgery. Can you talk about the recent advances, especially in meningomyelocele, diaphragmatic hernia, and posterior urethral valve?
So good question. So there are many fetal surgeries, and I think some of them deal more with the placenta, for example, twin transfusion syndrome, and doing a laser therapy on the cutting the communicating blood vessels. There are also ones which are, I would say, less interventionist, like say babies with a fluid collection somewhere, putting in like a stent. I mean, putting maybe like to drain the bladder or things like that if there's a posterior urethral valve. So those kinds of things are, I would say, much simpler to do. Myelomeningocele repair is being done at only a few centers because, again, it takes a lot of training, and people need to do enough of it to stay up to date. And so I think there are only 4 or 5 centers right now in the US which are doing it. It's not really cost effective to do it on a small basis. There are other things for, say, diaphragmatic hernia, where they put a tracheal plug, fetal tracheal plug, temporarily, and then remove it because that helps the lung develop. So the problem is it doesn't really work all that well. The alveolar development is still impaired. It still doesn't improve vascular development all that much. So it improves outcome, but it's not a total fix. So I think there's still a lot of work that needs to be done for fetal surgery. I think it needs to be done only in very specialized centers. I mean, we don't do it in all academic centers.
Right.
There was just a question which came into the chat about the use of NAVA in apnea of prematurity.
Yeah, so I think, yeah, so NAVA is neurally adjusted. So it works well for chronically ventilated infants who have a good respiratory drive, those who are breathing well on their own. But apnea of prematurity, it would work for obstructive apnea, which is a majority, but it doesn't work for central apnea, because if you don't have a drive to breathe, then it's not going to have anything to sync with. So it doesn't work if there is purely central apnea. So we don't use it for micropreemies soon after birth. We use it only in the infants who are older, who have sufficient respiratory drive. So for apnea of prematurity, it's not that useful.
Okay. And just to round it out, we talked about all the advances in the neonatal care, just a few of the things in critical practice over the last few years, which has significantly improved our preterm care, especially the use of steroids in late preterm births, magnesium for neuroprotection, and progesterone used to increase recurrent preterm births.
Yeah, so I think the thing about magnesium for cerebral palsy, I mean, that was the result of the BEAM study, where they showed that CP was reduced with magnesium sulfate. But if you look carefully at the data from the study, they show no difference in the combined outcome of death or cerebral palsy. But you do see a reduction in CP. So obviously, if you're having a reduction in one outcome, then the other one is going up. So you actually look at the data carefully, there is an increase in death in the babies exposed to antenatal magnesium. So I think it probably helps magnesium, say, for preeclampsia, but whether it actually improves preterm outcome, I'm not so sure. So I think even the other things, for example, for expanding antenatal steroids, I think expanding it to the lower gestational ages, say 22 weeks and so forth, is great. But I think bringing it higher, say the ALP study looked at steroids at later gestations. So yes, it does reduce the need for, say, oxygen, does reduce admission to the NICU, but does it really improve important outcomes? I think that's where we don't know whether that actually makes a big enough difference. So are the risks worth the benefit in the older infants? So I think a lot of interventions probably we need to weigh the benefit versus risk in each population carefully.
Right. If anyone has any questions or comments, please feel free to unmute and speak. Amit Ghosh, are you there?
Yeah, I'm there.
Hi.
I've been listening. Sometimes they ask me why I listen to a neonatology lecture, but I always admire people of greatness and always want to learn from them. So this is yet about an example. But what really struck me was neonatology. From the little I know and what Ambal has said, it's fascinating. It's like you're in an emergency room, but you cannot hand it over to somebody else, as ER people do. They hand it over to us or somebody. But you are the end all be all, and you are it. So you have to diagnose, you have to think big, and you have to act, and you have nowhere to go. So all this is a very, very difficult program. And in spite of the fact that Namma said that, you know, they live for 60 or 70 or 80 years, the rest of the world has not looked at these babies the same way. In fact, they're like immigrants who are 30 and 40 and can break rocks and start working right away without taking anything about their education and development and mental health and all that. So the challenge which Ambal is facing is going to be there forever. Having said that, the science is so very important, and the politics of the different governments has to cease, because whether you're poor or rich, a mother has a child and the mother wants to improve the life of the baby. And having a politics that you're doing for research or whatever it is which comes in the way really affects every child. And even in US, we have an entire diversity of population. They're not all rich, they're very poor. And you tend to get the same treatment because people have gone beyond it and trying to get the treatment to the baby. The same thing needs to happen in India, where rich people's kids will die and poor people's kids will die if science is not transported from other countries. So there has to be a democratization of these sciences. From the adult standpoint, what Ambal said about the endotypes is so very important for allergies, asthma management, and so many other things. It's very interesting how much we can learn from neonatology in adult medicine, and how there needs to be a very good back and forth, like cancer treatments being or techniques being used in pediatrics and neonatology and the other way around. So there is nothing else you can do but for confluence. It's like a common business of taking care of people and serving at all age. So whenever I see a scholar like Ambal, I always sign in, whether I understand or not, because it helps me understand that there is someone much smarter than me who's taking care of my grandkids if they have a problem. And I'm very thankful for that. And I would say keep doing it, and let's have more collaboration between India and US. Ambal is very open to it. And seeing Arvind after a long time brings me back memories of how we were together and in PTI and working together. And Ambal has the same thing. It's really wonderful to see how our careers have matured. And thank you to all the teachers like Dr. Vishnu Bhatt, Dr. Srinivasan, who have, beyond my wildest dream, they are probably one of the best teachers I've come across in my career. So, I mean, thank you for what you've done. And to Dr. Vishnu Bhatt and Srinivas, look at your students, how they have done and how they're carrying your baton. And please do the same in India so that we can bring all these great minds. And thanks to Vidya and Patta These two are very dynamic people. I don't know how week in, week out they act straight and get some of the best people around. And every week I tend to learn something. Thank you.
So over to you, Radha.
So Vidya, before that, I just want to say, I'm sure in that entire tome of Ambal's CV, he probably missed out a couple of things. So two things that I really enjoy through my virtual interactions with Ambal on Facebook are he posts some fabulous pictures of birds from his backyard. I mean, just absolutely amazing how he finds the time to do that in the midst of everything else. But even more interesting to me is that he posts some fantastic links to articles, scientific articles. So it's almost like having somebody curate it for you. So that's, so two things I'm sure he didn't say in his CV, but I absolutely enjoy that part. So just wanted to make sure that, people who are Facebook friends with Ambal should actually look for those things.
Again, it's a wonderful evening, great lecture, Ambal, I should say, even for a layman like me, who's nothing to do with neonatology. But the statement that struck me is that by saving a neonate, you're adding 60 years to a human life. I never realized the significance of it. We try to save older ones who are very closer to the grave, and we give our everything to that. And it's so nice to see again my classmates, my teachers, and also juniors who are global leaders in the field of neonatology. Wonderful, and it's a great evening indeed.
Your
Thank you all
closing
for
comments,
this,
Ambal. Sorry.
Yeah, thank you for this opportunity to share some of my thoughts with you all. I think it's really wonderful experience, and hope we have more of these. It's really thank you for organizing this for all of us.
Actually, we had a session on fetal surgery by Devnath, and we've had a session on neonatal intensive care in resource constrained areas by Sridhar Kalyan Sundaram. So we are not ignoring our neonates. Be sure
Good.
of that.
Excellent. Yeah.
So thank you, Suma and Ravi, once again for getting Ambal, and thank you, Hari and Arvind, for sparing your time, and thank you everyone for participating in a very active discussion. We'll see you again next week with yet another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.